introduce our next speaker, Dr. Anna Kagan. Dr. Kagan is a board-certified nephrologist and specialist in clinical hypertension. She completed her internship and residency in internal medicine at Massachusetts General Hospital, and then completed a fellowship in nephrology at Baylor College of Medicine. Dr. Kagan is one of our transplant nephrologists here at Houston Methodist, and is the chief of the Division of Nephrology in the Department of Medicine, and medical director of the dialysis unit. Her talk today is about blood pressure control and practical management tools we have available. Please welcome Dr. Kagan.
Thank you for that introduction and for inviting me to participate in today's symposium. What I was asked to talk about is practical management tools for chronic hypertension, and that's what we're going to talk about. We're not going to talk about sort of a comprehensive review of different hypertensive medications. We're not going to talk about the studies for blood pressure or the guidelines for blood pressure management, because those depend on a particular situation, particular patient. We're not going to talk about the acute management of blood pressure when patients are admitted with their neurologic insults and injuries. But we will talk about sort of a general view that I, as a nephrologist and as a hypertension specialist, see and to patients who have elevations in blood pressure. You're probably going to think throughout this presentation that this really belongs in a primary care conference, not a neurology conference, not in a stroke conference. But the reality of clinical practice these days, and especially following and during pandemic, is that people are no longer seeking primary care. They don't get to see their primary care doctors. They don't get to follow up on their chronic conditions that they may know or don't know that they have. And very frequently, the diagnosis of a chronic condition happens at the time that they present with their end organ damage, whether or not that chronic condition was the cause of their injury or it was associated with that injury. And similar to what Dr. Kent spoke about, a lot of times we'll get patients who find out that they have high blood pressure, elevations of blood pressure, when they present with strokes or with bleeds. And therefore, it's very important for us to know what to do with these patients, because that is the time that the treatment gets initiated. So we'll talk about what is blood pressure, or elevation in blood pressure, scope the disease, and then interventions, both the pharmacologic and non-pharmacological interventions for management of blood pressure, and what do we do when those don't work very well initially. I think we all heard that hypertension is a silent killer or the silent disease. And I think across both national and worldwide organizations, there are clear guidelines of what is considered to be hypertension. The reality of it, I think everybody agrees what is not hypertension. So if it's under 120/80, everybody agrees that this is probably normal blood pressure. Now, what is elevated blood pressure, pre-hypertension, and stages of hypertension really matters and depends on the particular guidelines. The American College of Cardiology and AHA came out with these guidelines in 2017, and they basically go anything, in gradations of 10 millimeters of mercury elevation above 120/80 is considered the pre-hypertension, elevated blood pressure, and then hypertension stage 1 and 2. J&C is a little bit less aggressive, so to speak, in their definitions. Again, agree that 120/80 is considered to be normal. Everything above that is not normal, and that's really the point here, normal and not completely normal. And their sort of gradations are by 20 millimeters of mercury. It's a common disease. If we look at the population 18 and above, about 50% of US population 18 and above have elevations in blood pressure. It is definitely much more prevalent once we start looking at patients who have illnesses, who have strokes, who have kidney disease, who have heart disease. It's more prevalent in men, and of course, older population also is affected more. The prevalence and control vary very widely by race, and similarly to glycemic control, non-Hispanic Blacks and African American population, there are more challenges in controlling blood pressure, whether it has to do with lesser recognition, hereditary factors, mutations that we know associated with blood pressure issues, or predisposition to blood pressure, socioeconomic issues, access to care. But regardless, there's definitely disparities there. It is a costly disease. It's not just a silent killer. It's also a very costly disease, about $130 billion annual cost in healthcare costs. And despite our best efforts, Despite prescription of medicines and educating patients, only about 25% of patients who would have a known diagnosis of elevated blood pressure are actually controlled, adequately controlled. So what causes blood pressure? As I mentioned, more and more we're now recognizing that there are particular mutations that predispose somebody to blood pressure elevations. Every single organ is involved in blood pressure regulation, both in health and in disease. This was not made by me. I do not think that the entire world is kidney-centric, but in reality, when it comes to blood pressure, many different components and issues from other organs all those roads will eventually lead to renal factors, whether or not it's through elevation of renin-angiotensin-aldosterone system or just volume retention because of salt and water retention and volume expansion. Kidneys do play a role in blood pressure management. Risk factors, right? So we talked about mutations, there's SNPs, there are predispositions, there's things that are controllable, there's things that are not controllable. So certainly the non-modifiable risk factors, nothing we can do about age, gender, race, family history, and in that, of course, falls the hereditary components with mutations. The modifiables are, dietary intakes, obesity, smoking, physical activity or inactivity in this case, sleep, and of course, social determinants of health. And then the medications, some of those are modifiable and some of those not. We can tell patients to stop taking their decongestants and non-steroidals, but if you need your chemotherapy agent, if you need your transplant medications, if you need your stimulants or SSRIs, you gotta take them, right? If that's the right drug for another medicine, you gotta continue to take that. We gotta have to deal with blood pressure in a different way. So once we know that they have elevation of blood pressure, I think it is important to establish that they truly have elevation of blood pressure. And as wonderful as it would be for everybody to walk around with 24-hour blood pressure, ambulatory blood pressure monitoring, that's not feasible. So whether or not it's repeating an office measurement or really engaging patients in trying to get home blood pressure measurements is important because that is going to be important in their care. Some baseline testing is also important, right? Not only will help determine if there is factors that may be addressed differently in control of blood pressure, but also will give you some basic characteristics, physical exams. Do they have volume retention? Do they have murmurs? I personally think it's important to get basic chemistries. Not only will it help you identify some problems, but more importantly, actually, it will help you monitor for some side effects of medications that may be given. As a nephrologist, of course, I think urinalysis is important, especially in our younger patients, because very frequently I'll see patients with chronic kidney disease, right, which is one of the issues that blood pressure is frequently associated with, who've been told that their kidney disease is due to blood pressure, but in reality, it's actually the other way around. Patients walk around with elevated blood pressures before we really see any significant manifestations in terms of chemistries, and we'll see a little protein in the urine, a little blood in the urine, and they have poorly controlled blood pressure because of underlying kidney disease, and that needs to be addressed a little bit differently. Again, that's a nephrology-centric view, but I think especially in our young patients, it's important to take a look at that. All right, so once you diagnose or once somebody's told that they have an elevation of blood pressure, whether or not it's pre-hypertension or hypertension stage 2, I think everybody has to have a chance of thinking about modifying their lifestyle. Because some of those things do make a difference. It is hard to do, and of course they need to want to modify their lifestyle, and they need to be able to continue to do that consistently. This is, resolutions last a very short amount of time, so even when they're driven by medical problem. So what really works, what really doesn't work, people need to know. This is sort of a best summary that I could find. DASH diet seems to be the highest hitter. It brings about 10 millimeters of mercury in systolic blood pressure decrease if you can stick to a DASH diet, and that's a reduced salt intake and increase sort of fruits and vegetables intake. Increasing potassium intake, this is the fruits and vegetables come through. Hypokalemia causes vasoconstriction, so when people increase their potassium, sometimes it helps in blood pressure management as well. And of course, physical activity, moderation of alcohol is important as well. These interventions help, but they do have cumulative effects, additive effects, but they provide only a relatively small changes to the blood pressure management. Some of the things that are not on this slide and I think are important is sleep. When they looked at patients who sleep or people who sleep less than 7 hours, if they're able to increase their sleep duration by another 40 minutes, that dropped their blood pressure by 7 millimeters of mercury in the systolic blood pressure. We hear this everywhere, right? I'm stressed, that's why my blood pressure is high. Whether or not it's white coat hypertension or the stress of something else, we hear this all the time. I don't have high blood pressure, I don't like being here, I'm stressed about being here, the traffic was terrible. They still have high blood pressure. And there's definitely mechanisms, right? The increased catecholamines, heart rate goes up, cardiac output goes up, blood pressure goes up. There's definitely basics behind that. When we looked at multiple studies, across whatever stresses you want to think about, whether it's job stressors, financial stresses, family stressors, socioeconomic stressors, reducing those stresses does help with blood pressure management. But again, we're talking about 3 to 5 millimeters of mercury changes in the systolic blood pressure. An interesting study that I recently read is patients who were following their blood pressures continuously, right? So there's large studies that having patients measure their blood pressure and sort of send that information. What happened in the beginning of pandemic when we all thought that stress was really high? And during that particular time, so in 2020, in the first 8 months of pandemic, two things were noted. Number one, in the first few months, nobody was measuring their blood pressure, so the number of measurements dropped down significantly. And number two, when you actually look the first 8 months of pandemic, then pre-pandemic and after kind of things started to settle down, the blood pressure did change by about 3 to 5 millimeters of mercury. So there's definitely some effect of stress, whatever you're going to define it. But it's not a very large effect. So stress does matter, but once people come down, they need to measure their blood pressure because we sometimes underdiagnose hypertension because of that. Caffeine is a very common thing we talk about, right? So everybody says, I just had my coffee, therefore my blood pressure is high. Probably, again, we can find mechanisms behind that, but in reality, caffeine actually has protective effect, right? I think we all have seen studies that, 2.5 to 3.5 cups of coffee per day actually may decrease cardiovascular outcomes. I strongly believe in that as a big coffee drinker. All right, so lifestyle modifications, everybody needs to be offered that. Whether they do that or don't do that, that's really up to the patient. All we can do is, counsel and lead the way. Medications, right? So when do you start the medication? I think the main take point, I think, here is that inadequate treatment or therapeutic inertia is actually a big problem. It's a big problem in hypertension management, it's a big problem in prediabetes management, and as Dr. Kent showed us, it probably has effects on outcomes in chronic diseases, right? So therapeutic inertia actually, whether not initiating therapy or initiating therapy and not getting the goal blood pressure management, probably actually has a larger impact than what we talk about a lot, which is patient non-adherence, which is a huge issue. But if we don't offer them the medicines, they're not going to take them anyways. There's no clear consensus when to start. Certainly, if in a primary care setting, if somebody comes in with a blood pressure of 142/85 and they want to try to lose weight and exercise, that's great, right? If somebody comes in with a similar blood pressure, but they just had a hemorrhagic stroke, that's probably not great. You've got to treat that a little differently. So different situations call for different aggressiveness to starting therapies. Original studies, so the very first study of first-line therapies was in clostridone, which is a thiazide diuretic. At this point, all the guidelines and all recommendations are not to say that there's one particular drug that you should start with. The typical first-line therapies are thought to be thiazide, ACE inhibitors, ARBs, and dihydropyridine calcium channel blockers. Beta blockers are not the first-line therapies in general population. Now, again, there are populations for which that's an important therapy and maybe the only blood pressure medicine that they take, but that's not the first-line therapy. And certainly, if you have somebody who comes in with a higher blood pressure, so whether it's greater than 20 millimeters of mercury above the goal on the systolic or greater than 150/90, you should consider starting them at two drugs at the beginning, not wait for one drug, because chances are you're not going to get that needed response quickly and appropriately with just a single therapy. The good news is that pharmaceutical industry has provided a lot of dual combination drugs, so a lot of ACE inhibitors and ARBs coupled either with the hydrochlorothiazide or with the hydropyridine calcium channel blockers are available. And really the only study that sort of gives you a selection is, in the ACCOMPLISH trial, when they compared the ACE inhibitors and dihydropyridine to calcium channel blockers, they actually had a decreased risk of non-fatal cardiovascular events, including stroke, in that trial. So that may be a good option to consider in somebody as a secondary prevention. I think it's incredibly important to talk to patients about their side effects, right? And give them anticipatory guidance of what to expect from these blood pressure medications, because they'll read it, they'll see something, they'll stop it, they'll tell you never told them about. So the more they know what they may or may not face, I think usually helps with adherence. Teaching them or trying to get them to start measuring their blood pressure helps with adherence as well. But, the more you warn, the more you talk about it anticipatory, I find that the better off they are, and there are studies to support that as well. All right, so what is the treatment goal of blood pressure? Again, varies, very different guidelines, varies on the clinical presentation, varies on your patient, right? Varies on how they tolerate the medicine. Some patients do much better with certain medications, some don't. So it's all about risk-benefit ratios in those situations and what are you trying to achieve. Just to mention the JNC, about 5, maybe 8 years ago now, they came up with a little bit what people consider to be a little lenient thoughts on what blood pressure management is. But the important things here are the two things. Number one is that if you have a general population, somebody over the age of 60 doesn't have any other comorbid conditions, particularly diabetes and chronic kidney disease, you should keep them under 150 over 90. Really, the takeaway point is you should keep them under 150 over 90, but you should treat your older patients. A lot of times people think our older patients don't need tight blood pressure management, there's perfusion issues, there's concerns. Many studies have shown that you actually, older patients in their 80s, that's some of the subsets have shown, do benefit from blood pressure management. They don't need as tight control, but you need to treat your older patients. Everybody else, less than 140 over 90. Of course, societies come up, the nephrologists would say, 130 over 80 in certain situations. Whatever the goal that you're going for, you need to try to reach the goal. And to do that, short-term follow-up, monitor tests, side effects, kind of make sure that people follow, make sure that they continue to do that. So what happens when you give them the drug, they go home, they start taking it, they really are taking it, supposedly hopefully doing their lifestyle modifications, and they still have not achieved that goal. Again, this is where short-term follow-up is needed to make sure that you don't sort of promote that therapeutic inertia. Secondary agents, whether diuretics or calcium channel blockers are usually thought about, and make sure that they're actually doing their lifestyle modifications, or they go back to the lifestyle modifications if they want to continue to do that. If that fails, you add a third agent. At that point, it's probably a good idea to make sure that diuretic is in the mix, because most patients' volume retention is a component of that, so it's a good idea to make sure it's in the mix. And again, make sure that should they choose to adhere to lifestyle changes, we can tell what they want. If not going to adhere, you're just going to have to increase the medicines because they're not going to adhere anyway. So if that costs more medicines, we're going to do that. All right, treatment-specific conditions, stuff on the left, things that are a little bit more driven by data. If you have people with CHF or coronary artery disease, some of the goal-directed medical therapy should be included in that, and choices of medications may be based on that. If you have patients with some other conditions like BPH, sometimes we make different choices in the blood pressure medications. Migraines, the same thing, beta blockers on non-dihydropyridine calcium channel blockers. Sometimes that's a good option to start if they only need a single agent. Again, only 25% reach their goal blood pressure management. And another 25% nearly require 3 or more drugs to control their blood pressure. They're considered to be apparently resistant if it's more than 3 drugs, and apparently refractory if it's more than 5 drugs. So when do you start thinking about sort of additional secondary causes of hypertension? This is not something, a lot of times we thought about essential hypertension and secondary hypertension. It's not that simple. Most patients, or a lot of people have essential hypertension, then may have additional or secondary causes. True secondary hypertension is incredibly rare, but we still need to think about it, or at least in addition to the essential hypertension. So certainly your young patients, we don't have a clearly defined risk factors would be one of those. Those who come in with really severe high blood pressure and already end organ damage by the time they present with blood pressure issues. If their blood pressure is labile and they're taking their drugs consistently, I saw a patient yesterday who, takes some day at 8 o'clock in the morning, sometimes she'll take it till 11 o'clock at night, right? Her blood pressure is labile. She doesn't take it consistently. If they're taking it consistently and labile, chances are there may be something there. Of course, electrolyte disorders, hypokalemia, alkalosis can get that, and accelerated high blood pressure. So what things to consider? Obstructive sleep apnea, pretty simple to at least detect. Chronic kidney disease and kidney issues, right? This is not just in renal vascular hypertension, but they could have underlying chronic kidney disease or proteinuria disorders or nephritic disease that could contribute to high blood pressure. And high blood pressure may be the only manifestation of that disease at that point. We all talk about renal vascular hypertension, renal artery stenosis. They're young with fibromuscular dysplasia, and then the older ones who have diffuse peripheral arterial disease. Renal arteries are just one of them. They usually are very severe. They have spikes because they have coronary disease. They'll frequently flash pulmonary edema. Imaging, ultrasounds, MRIs, other interventions, to look into that. As a nephrologist, I've never seen the initial hypertension of coarctation of aorta, but you guys see younger patients sometimes, and that's not unusual for those patients who present with stroke. Primary aldo is something that's underdiagnosed. I think there's many more patients who have it. We don't really think about it a lot. Everybody waits to see the low potassium and alkalosis on blood work. It doesn't usually happen. So if they need multiple agents, and especially if you added an MRA that we'll talk about in a second, narcotic receptor antagonist in a second, and they get better, go back and check on that. There may be a way to intervene on that. Pheochromocytoma, everybody wants to talk about it. Everybody thinks they have it. It's very rare. It's very paroxysmal. We don't typically see the triad of headache, sweating, and palpitations. But at some point, if they have spikes and they're really labile, it's probably a good idea to check. Low suspicion, check urinary catecholamines. High suspicion, check plasma catecholamines and metanephrines. Rarely, but it is diagnosed. All right, and so what do you do when you've tried 3 agents, you've made sure they don't have secondary causes or secondary additional causes, you've addressed those if possible, but they're still blood pressure. They take their medicines. You sort of trust them that they take their medicine, or they will take their medicines the best that they can take them, and they're still resistant. This is when we start sort of opening the door, and this is where the data, there's no evidence behind. This is really just trial and error. Hopefully, as more and more information is available about specific SNPs and genetic predispositions, there's going to be more of a tailored therapies as opposed to just pure trial and error. But triaminocorticoid receptor antagonist, right? That's the spironolactone. I think that's not a bad 4th agent, right? If they're not hyperkalemic, that's not a bad one to think about. If they drastically improve their blood pressure, go back and make sure there's not an adrenal lesion. A lot of adrenal lesions are underdiagnosed. Add a beta blocker if they're not on already. Most of the patients will be at that point. Add hydralazine if they can handle it. Consider other agents. And again, the choices of other agents is really just a selection, right? You can try, of course, dexazosine, clonidine, the minoxidils, isodils. It's what they can tolerate, how they can tolerate, and what they're able to do. And then finally, if all else fails, if they don't do well with medications, if they're truly taking all the medications and they're not getting better, then to consider interventional vascular procedures, whether that's renal denervations, renal artery stenosis opening, that's something to consider even earlier, but those things to consider blood pressure management as well. And I'm gonna stop here. Thank you for your attention, and if you have any questions later on, please feel free to email me as well.